Hello, this is John Kanelopoulos from our office in Athens, Greece, clinical professor of ophthalmology at NYU Medical School in New York City. This is quite an interesting case. 72-year-old lady. She had 24 years ago a very successful graft for keratoconus that, as you can see, subsequently also had cataract surgery. She has very severe astigmatism, over 20 diopters. And as you can see here, the graft-host interface inferiorly has dehisced. There has been a quiet shift there from obviously persistent eye rubbing, and we're trapped in these situations to address this. If we only look at the corneal topographies as quote-unquote recurrent keratoconus, we're going here in the Scheimpflug image topographies, and of course the upper left image shows some inferior steepening that resembles keratoconus, but when we look at the bottom left map that shows the thickness of the cornea, and flags red where the graft-host interface is, we can see that that interface has thinned tremendously and is bulging out. So in my opinion, addressing this with refractive surgery is not the treatment of choice. We will go into the graft-host interface and try and revise it. I'm going to try and show you this again with another elegant way. This is the anterior segment OCT by OptiView, and you can see in this cross-section the severe thinning of the graft-host interface. It happens usually inferiorly, and it is from overt eye rubbing that these patients never cease to do. So in case of redoing the graft here, we opted to go back. You can see here a 15-degree blade and manually reopen whatever is left from that graft-host interface. Quite careful, this is done under peribulbar anesthesia. That's why you see the patient poorly reactive, and obviously this is surgeon's view, so everything is upside down. So carefully go manually. There is some resistance, as you can see there, in the areas where the original sutures were placed. Obviously the tissue there is more fibrotic, both on the graft and on the host. This is, for example, an area of resistance. And I'm spending a lot of time to show you this because we like to expose all this graft-host interface and now soak it with Vibex Extra. This is a 0.3% riboflavin, and I will do this all along suturing this inferior part of the graft-host interface, so about 180 degrees worth of that interface. You can see the sutures are placed almost full thickness, suturing quite tight here. I'm trying to bunch up all the loose tissue and obtain, if possible, an overcorrection. You probably suspected right that following this I will perform a cross-linking session in order to reinforce the host cornea that has a significant ectatic. I will, at the end of placing these sutures, place even more Vibex Extra 0.3 riboflavin. This is a higher concentration, and come to the CXL2 device by Vidro. We'll place it over the patient's eye. It has a tracker, and you'll see why. Because the cross-linking here will be performed with very high fluence, 30 milliwatts, for a total of 15 joules delivered at the periphery of the cornea. And we'll see an image here. You can see how nicely the hyperfluorescent ring of the UV light on the cornea, only in the perimeter of the graft-host interface. Well, obviously, suturing alone will give great results, and we can see here a slit-lamp photo several months later. Obviously the sutures are still tight, and you can also see the slight haziness in both the graft and the host, which was achieved from the cross-linking process. And obviously the tissue there is, in lack of a better term, bunched up. We're going to see some further nice images. You can see here the before and after, and how we're able to bring back this tissue together and follow our quest to reduce the very high astigmatism in this cornea. Surprisingly, this cornea 24 years later has a cell count of about 1,200 cells per centimeter per millimeter square. So not necessarily a cornea I would like to regraft. Again, another section from another part of the cornea. Bottom is before, top is after, and you can see how nicely we're able to reoppose the tissue. You can also see from the hyper-reflectivity of that graft-host interface in the superior image the cross-linking effect that we see in corneas that we cross-link for primary keratoconus or ectasia. And here again, I just want to remind you the cornea thickness maps by Scheimpflug tomography, and the severe inferior steepening that we encountered in this patient. Again, best corrected here was 2200, and she was recommended to redo the graft because new keratoconus had occurred within the graft. We now know that that was not the case, and we'll go to the post-op tomographies with Scheimpflug, and you can see how nicely now circled in red the graft-host interface is not anymore thin inferiorly. We're able to redo this degeneration, if you may, from continuous rubbing. Of course, reinforced with this patient and any keratoconus patient that eye rubbing is a pivotal part of therapy with this disease. We'll see some more images here showing the before and after difference. Before is on the left, after in the middle, and the dramatic flattening of that very regular area that, in my opinion, is partly due to re-suturing and bringing back that wound together, and the higher, very higher fluence cross-linking and higher energy cross-linking that we performed in order to stabilize the result. I will, of course, delay removing those sutures. Again, some nice anterior segment images with the OptiView OCT. I mentioned that we'll delay removing those sutures as long as we can. Patient is to corrected 2040, uncorrected 2060. I think, in my opinion, a fruitful intervention for the patient. Thank you very much for observing this, really.